The weight of your head's 11 or 12 pounds, and you get into a whiplash trauma where that's moving forward and hyperextending at 6 to 10 Gs. If you get the head in a lot of lateral flexion and try and manually adjust that, I mean, who's to say that those membranes aren't already shredded from the whiplash trauma or the concussion? And again, that's why I love you guys' work so much, is because these upper cervical specific adjustment doesn't create any torsion on those ligaments, so we can restore better positioning of the spine. You guys can get in there underneath those levels, at, the lower levels of the spine, and get those ligaments more stable and healing themselves throughout the whole process.
I love the fact that you get it. Just recovering from injuries is one thing. It's another, when we develop chronic and degenerative conditions. But a lot of times, chronic and degenerative conditions come from the dysfunction, related to many of the things that we're discussing. You spent a lot of time talking about technology and just kind of what it is that you do, and obviously you're really passionate about it. So, for me, I think, I know how I feel about what you do, and I understand it. But I don't think a lot of people do. You know what I mean? So I kind of wanted to hear it from you, because you specialize in a very unique style of practice, right? You're not just a chiropractor, you're a specialist in upper cervical work. And I guess, that's really what I want people to understand. Full disclosure, you're treating probably almost every one of my team members, and they're all extremely happy. So why don't you kind of explain what that means? What is upper cervical work? What makes you different? How'd you end up in that position, really?
What got me into upper cervical work was I had a 38-degree scoliosis. I think I might have told you this earlier, but I was 9 years old, and Julie very well. I went to the same Skycrest Christian School, and my mom worked there, and my mom was telling some other mom about my pre-op, x-ray. It was 30-something degrees of curvature. I don't remember. I was 9, but I just remember it was a lot. And, she was talking to another mom, and if you know Julie very well, Julie being Julie, she overhears, something, she runs over there, and she goes, "Hey, Pam, what's going on?" And so my mom explained it, and she goes, "Okay, well, give me 5 or 6 weeks. Let me see what I can do." I do, upper cervical chiropractic care. We had obviously my mom and I had no idea what that was at the time. But she goes, if they still want to do the surgery with the Harrington rods in his thoracic spine, then do it. But if they don't, might as well try this. So she goes, sure, why not? 5 weeks later, they took a pre-op x-ray. It was 1 degree. It's actually still 1 degree. I had Travis x-ray me 4 years ago, and it was still 1 degree. And obviously we don't make those changes with people our age, but with a 9-year-old and a functional scoliosis, you can really change that.
Yeah, it's pretty awesome. And the 39 degree...
It was 30-something degree. I don't remember. It was...
Either way, it's tremendous. So that was sort of how you found upper cervical work, which is pretty awesome. Why don't you kind of explain what upper cervical work is? Because I don't think a whole lot of people understand that.
Obviously, the chiropractic subluxation is, the movement of a joint not fully dislocated, far enough off alignment that it impedes neurological function from the brain, the connections down the peripheral nervous system. We both know that as chiropractors. Chiropractors preach that to their patients. They remove subluxation, get the nervous system to work better. Awesome.
Yeah.
Upper cervical is the same thing, but as you know, C0, C1, and C2 are the most complex joints pretty much in the entire spine. I guess you could argue the sacrum, but you got the base of the skull here shaped like this. You got the C1 body in the middle, and then you got C2 like this. So it's a biconvex joint where it falls off one or the other. You manually adjust C2, C3, C4 down the line, thoracic spine, lumbar spine. Unless that correction is the word I like to use, or adjustment, at C1 is specific, you're not going to get the best restoration of brain and spinal cord function unless that adjustment there is specific, if that makes sense. You can be a little less specific the rest of the way down.
Yeah, it does. And I think that most people don't really grasp how important that area of the body is, not just to the from a structural standpoint, but from a neurological innovation standpoint.
So let's get into your world. You've got 2 alar ligaments, a transverse ligament, the atlanto-occipital membrane, tectoral membrane. There are so many ligamentous structures there that, the weight of your head's 11 or 12 pounds, And you get into a whiplash trauma where that's moving forward and hyperextending at 6 to 10 Gs. If you get the head in a lot of lateral flexion and try and manually adjust that, I mean, who's to say that those membranes aren't already shredded from the whiplash trauma or the concussion?
Sure.
And again, that's why I love you guys' work so much, is because these upper cervical specific adjustment doesn't create any torsion on those ligaments, so we can restore better positioning of the spine. And then, in cases I send to you, which are a lot of them, I actually have a few more I'm sending in like the next 2 weeks. You guys can get in there underneath those levels, the lower levels of the spine, and get those ligaments more stable and healing themselves throughout the whole process.
Yeah, no, it's awesome, and I love the fact that you get it. That's really an important piece of it. Like, just recovering from injuries is one thing. It's another, like when we develop chronic and degenerative conditions. But a lot of times, chronic and degenerative conditions come from the dysfunction, related to many of the things that we're discussing. And it's interesting to me because it was a blessing that I got to learn some upper cervical work at the school that I went to. But like most people, it doesn't necessarily resonate with everyone. But I see, like, just for example, like Maria, my office manager, I mean, she's been dealing with neck pain and upper back pain for as long as I know her, which is over 10 years. She's been everywhere. I routinely adjusted her whenever I had downtime. We've done stem cell work on her, and she never really improved, and then she gets one adjustment from you, and she's like a different person. So like for me, I'm like, I don't know what he does, but at the end of the day, like, everybody should take part in it,
Yeah, and with her, it wasn't necessarily, she has the curvature as well. We couldn't fully correct that curve. She's not 9 years old. She's, however, older,
Right.
our age-ish. And, it's not that we removed the curve. We took the interference from where the brain meets the brainstem meets the spinal cord out, and that took X amount of pressure off of her ligaments and joints, and then that chain link the whole way down, and that's why she did better.
Yeah, totally. And you know what, there's so many misconceptions when it comes to like manual adjusting. Like, we're talking about brainstem, we're talking about cords, like, and when we throw those words out, people get a little nervous. So what are like common misconceptions about really your specialty specifically that I guess maybe you wish more people understood?
So what I try and explain to patients is that little gap from here to here is, just the way I verbalize it, is the most neurologically densely packed area of the entire body, period. Cerebellum, brainstem, beginning of the spinal cord, all those ligaments we already mentioned. And there's just a lot of functions, especially autonomic functions, that run through there. So with the upper cervical specific adjustment, depending on technique, but most techniques, it's delivered side-lying with just a very light 2 to 4 pounds of pressure force on the transverse process to help slide that back under the base of the skull. And whether it's Blair, NUCA, orthospinology, Atlas orthogonal, advanced orthogonal, Epic, whatever, we're just trying to create as much space out of the foramen magnum as possible. That's literally the goal with all of us. But I think the biggest difference between upper cervical specific adjusting, and manually adjusting that area is that we don't put any excess load or tension on all of those tiny, tiny, tiny ligamentous and myodural bridge structures up there. It's a very, very light force, but it's just enough to allow all of those autonomic things in that neurologically densely packed area get all the messages out more effectively.
Yeah. So, and that's really it. Like I don't even consider there to be any risks associated with that. Like at the end of the day, like once you understand the neurology, and I know that a lot of people, if they watch this, probably won't understand what the foramen magnum is and the space that you're kind of describing. But essentially, it's the space where your brain meets your brain stem and it extends down into the cord or into the spinal canal. And because the atlas is a ring, it can be moved off center to a degree where there's less space for that neurology to occupy. Right? Yeah, perfect. So really, your job is just to kind of realign the atlas so that we can take whatever mechanical stress might be on the brainstem specifically, right? And the dural structures that are associated with that, which is the sac that kind of houses it. And that plays into, because I did go to a seminar with Julie years ago, and she talks a lot about CSF flow and TBIs and all of that stuff. And that was one of the things that really stood out to me in terms of our
Yeah.
conversation, because yes, you do treat accident cases, right, which is really important. But at the end of the day, a lot of what comes with that is
Yeah.
brain injuries. And, to some degree, why don't you explain a little bit about like the role that upper cervical work plays? Because for me, the way that I look at things, you know, whenever somebody gets injured, we always err on the side of
Correct.
conservative care first, right? We have to allow the body to normalize and heal itself. We have to provide an improvement in function, allow their body to do what it's supposed to do. And then if they don't make it out of that process and they need an interventional, let's say, procedure, then we kind of progress them along. With surgery as a very last resort, unless it's clinically
Yeah.
indicated immediately. So I know that TBI is like a big deal, because now we have these conservative efforts that can possibly move the needle for those individuals, which are really significant
Yeah.
conditions. But what role does like upper cervical work play in TBI specifically?
Yeah, so it's a big word, but craniospinal hydrodynamics. So that means cerebrospinal fluid and blood flow. And essentially, if I ever get a traumatic brain injury patient, we look at the MRI imaging to see if there's any excess white matter or CSF, pooling in the brain. And then number two, the DTI SWI, we want to see if any axonal pathways are sort of, disconnected, and try and, reconnect them through getting the CSF moving better. When I get a TBI, I'm always trying to get the spine in a better position, but the outcome I want from that is better improved cerebral spinal fluid flow and simultaneously no internal jugular vein occlusion. And the reason why I say that is because when we're upright in our day-to-day, like we are right now, that CSF created in the brain, going down the canal, back up and down, twice a second, 80% of it drains out of the central canal, this space right here. But 20% of it comes out of it gets filtered through the bloodstream down the internal jugular veins. And what I see mechanically a lot with traumatic brain injury is that the rotation, I got a big keychain, sorry. The rotation in an anterior fashion of C1 can mechanically occlude the jugular veins. I see it a lot on MRI, especially Dr. Julie's CCJ slices, just with mechanism of injury that happens a lot. So we try and open space for the internal jugular vein to pulse out the excess waste from the brain. But just long story short with TBI is that the metabolic cascade that happens is there's a TBI or mild TBI. The microglia, which I call the street sweepers of the brain, become inflamed, and the cerebrospinal fluid helps those move around the brain and go back to street sweeping, and then flushes out whatever waste is there. When the traumatic brain injury happens, those street sweepers get primed and they become inflammatory. So if the CSF, if that pathway for it to drain things is blocked and there's pooling or backup, whatever word you want to use, those primed inflamed microglia, the M2, stay inflamed. So that could stay for a year. Patient, it won't make big of a deal. But then you're talking 5 years, 8 years, 12 years, 20 years down the road. If those are still prime and inflamed, you think you're still going to have symptoms from TBI at that point? Yeah, absolutely. So again, it's theoretical because we can take post MRIs and things of that nature. But, in theory, when we correct the positioning of the upper cervical spine, we want to improve CSF flow to get those microglia back to M1 and uninflammatory and get back to their job of going around the brain and cleaning up those toxic proteins like tau, amyloid beta, the things that lead to MS, Alzheimer's, the neurodegenerative conditions of the brain that happen when that happens. There's 1 trillion studies on, people 30 years after a TBI, their incidence of, MS, ALS, Alzheimer's, dementia, you name it, neurodegenerative, is like, 40% more of a risk ratio. Well, if we get that fluid flow improved immediately starting post-trauma, that risk ratio, I'd assume, would have to go down. I don't believe there's a study on that yet because it's very longitudinal, but I would have to think that that would be the case.
But at the end of the day, it
Yeah.
just makes sense. And TBI is one end of the spectrum, right? So, what role does upper cervical work play in just general wellness in terms of getting things moving, allowing your body to regulate? That's really interesting.
Yeah, this is something we've pretty much dove headfirst into in our diplomate program. Yeah,
Yeah, so cool. What about because what you mentioned at lunch was like you're a tech guy and you got all these little,
yeah,
like really cool devices that allow you to
yeah,
diagnose effectively. Um, what are those? I mean, maybe just explain a little more detail what they
100%.
do. You know what I mean? Because I'm
Yeah,
not a tech person. Like, how do they work, and like, what kind of information are you gathering to
no,
make the diagnosis? I know the MRI
yep,
and all that stuff,
right.
really
And
important piece
yeah,
of the
and we're not
puzzle.
going to send a patient for an MRI every week to double check on this stuff because that's just not feasible for
Sure.
anyone. So it's exactly correct.
Yeah.
So I actually should be in Iceland right now, but I missed out on the conference. It's a company called Neck Care. It's a little headband. You just put it on like this. It measures range of motion with accessory motion, which is huge for me, joint position error, and sensor and motor control of the neck. So a key symptomology component of TBI is patient usually has brain fog, they have headaches, neck pain, and dizziness, imbalance, vertigo, and difficulty moving the eyes somewhere in there, whether it's all or some. So with neck care, we can look at range of motion. Me and you as a clinician could eyeball it and probably be within 5 degrees. That's not too big of a deal. But the joint position error test, and I don't know if you've looked at this test much, but I mean, there's a lot of evidence for it. And it pretty much, it's proprioception of the cervical spine, which gets, you lose that when you have a whiplash or concussion. So it leads me, if a patient comes in immediately post whiplash concussion, you're not really sure. We put that on, we do the test. If it's a horrible result, that leads me to think, hey, there's probably some of this here, whether it's whiplash or TBI or both. And then the butterfly test, which is their sort of patent, it runs off the joint position error. You follow an object around with your neck like like watching a butterfly. And that essentially it's like handwriting. If you can't look at an object and be able to follow it with the neck with good control, there's probably some misconnection there of function of the cervical spine to the brain.
Absolutely.
So if they get horrible results on those two tests, okay, let's get the MRI, let's look at this, let's see what happened. There's a high chance or probability that you probably did have either whiplash or concussion or both. It's kind of hard to explain neck care. I mean, really just looking at the test, you'd be like, oh, I get it. I don't get paid to say any of this and I pay for it. So, it's not like but it's one of the best diagnostic tools I've ever been able to use. Honestly, once I understood how to use it.
Awesome.
Yeah.
It's really cool because tech is moving at a rapid pace, and it's crazy to think, where we were even 5 years ago, and even crazier to think like in the next 10 years what might be taking place. So it's really cool stuff. Is there anything you see coming down the pipe that's going to aid in either the diagnostic component or possibly like even in the treatment component or the clinical component?
Diagnostically, I believe, I don't know if it's advanced diagnostic group, but there's a group off Kennedy that Dr. Julie's working with that's getting a functional MRI scanner, and you'll be able to see spinal fluid move and where it's getting impeded, whether it's, maybe in the frontal lobe, maybe it's a frontal lobe injury, or if it is in that craniocervical junction area. I know that's close, but I don't know if it's there. I think it's installed. So that's one facet, that's evolving rapidly. As far as treatment protocols, I stick with orthospinology, their textbook. That's the technique within upper cervical I use. That's how I get the head neck realigned. So as far as treatment, nothing evolving too crazily there. But diagnostically, absolutely, that functional MRI can be massive.
Yeah, it's interesting. There's a little bit of a disconnect on that front from a TBI perspective, right? We have all these wonderful diagnostic tools coming down the pipe and not a whole lot of therapeutic options,
Yeah.
right? And I love the neurodiplomat program and a lot of Carrick's work and all that stuff. I think it's great, but it's relatively limited. You know what I mean? Especially when we have significant structural changes, you know. So, you know, maybe one day we'll be able to catch up. I know that there's a regen program for TBI that I'm looking at, but it's one of those things, you know, obviously whatever we can do to help people, that's always the most important thing, right? I know that you're a passionate clinician and that's your primary objective. That's why you resonate with me, I should say. So it's really great. Is there anything else like you feel like talking about or telling people like, you know, what makes you special? And
Yeah, I mean, as far as upper cervical, I'm so passionate about it because A, I was a patient, you know, number one, and it had nothing to do with the brain. But B, you know, I was just working for Julie in college. I thought, you know me, I used to be good at golf. I thought I was going to turn pro and stuff. So yeah, so I was working at her office in the summers to pay for my amateur tournaments. And, you know, I'm just thinking, you know, yeah, this adjustment helps people, whatever, you know, I don't know the science behind it. She pulls me into her office. She goes, come here. This is what got me all in. She had an MS patient with, you know, dime-sized lesion load. And it was either, I think after 8 or 16 weeks of care, I think she published a case study somewhere. She got a post-MRI, and that lesion load was like gone. And I go, wait a minute. And I was like, that happened with upper cervical. She goes, yep. Patient, you know, that was really the only treatment she was undergoing. And I was like, okay, I'm all in on that. I was like, I said, you're actually making those functional changes in the brain. And she goes, yep. And that's what made me all in. I was pre-med at the time at Stetson where I was playing golf. And, you know, I didn't know maybe ortho, you know, I didn't know what I wanted to do. But I didn't realize, and that was at the beginning of all their research when they were finally starting to look at this on MRI, her and Dr. Rosa. That's what made me all in. And now I understand it's because of the improved hydrodynamics of the fluid, the cerebral spinal fluid. I get that now, but at the time I'm just going, I had no clue it was making these type of changes in the brain.
Really cool. And that was one of the things I wanted to display more than anything is chiropractic is a wonderful tool. But they're really like in traditional chiropractic, when you're dealing with C2 and below, you don't have the same dramatic effects. I mean, yes, we can see like there's miracle stories of people who, you know, regain functions and we see some really amazing outcomes. But at the end of the day, when you're working, you know, in an area of the body that is really complex and many of the like the regulatory patterns in your central nervous system rely on that area specifically. It's pretty cool that you can see those kind of changes, and I don't think that many people ever are aware of it. You know what I mean?
I even say this to patients and other docs nowadays. I'm like, you know, trauma is not what it was 40 years ago. Cars drive faster, athletes hit harder, they run faster. You know, you see those hockey guys playing. I love the Lightning. I mean, they're skating at 30 miles an hour, hitting somebody with 240 pounds. It's got to be at least 20 G's. You know, the brain aspect of upper cervical care is really what drew me to it, and the changes we can make with that are life altering. That's what really, you know, keeps me passionate about it.
That's awesome. We'll have to sit down one day and see if we can figure out, you know, what adjunctive therapies that are all obviously in line with what it is that you're trying to accomplish would be able to move the needle, you know? Like I'm thinking off the top of my head, like peptides and even regenerative medicine to a degree, as long as we can get a really good process where we can get reproducible outcomes. That would be the most important thing, obviously. And then also we have to deal with a little bit with the regulatory environment and decide what we can do and what's clinically appropriate for people, right? Well, Doc, look, I really appreciate it. I look forward to possibly maybe playing some golf with you.
We'll get to it.